All right, let's go ahead and get started. Just give me 1 second. All right, good morning. Today is the grand rounds for the Department of Internal Medicine. Today is Thursday, October 5th, 2023. Today's grand rounds is one of our special sessions, Morbidity, Mortality Conference and Quality Improvement Projects. So led by our quality safety folks at the department level and health system level. So pleased to have a panel of discussions today. So before I get into that, just a couple of quick things, some reminders. These are some upcoming events for the Department of Internal Medicine coming up. So we'd love to have folks join. Faculty and residents and trainees are welcome to our sessions. And for the CE credit today, this is the code if you want to take a snapshot with your phone. If you are online, you can also take a quick snapshot. They will be available at the end again. All right. So that's not time. All right. Welcome. Let me introduce our speakers and panel today and then get us started. If you're here in person in the George Ben Johnston Auditorium, if you could silence your cell phones, that would be helpful. If you are online, you are welcome to come down here to George Ben Johnston Auditorium each Thursday for the remainder of the season. So let me start. We have 6 speakers today, a panel of 6 moderated by Dr. Carolyn Marcelo. Dr. Marcelo received her MD degree in 2013 from West Virginia University, completed her residency in internal medicine here at VCU in 2016, subsequently joined the Division of Hospital Medicine. She is serving as the Quality and Safety Director for the Internal Medicine Housestaff Services since 2021, and she's an Associate Professor in the Division of Hospital Medicine and past Grand Rounds Medical Director. We have Cassandra Baker with us today. She's a critical care pharmacist in the cardiac surgery and coronary intensive care units here at VCU. She attended University of North Carolina School of Pharmacy for her doctorate in pharmacy, followed by 2 years of postgraduate residency training specializing in critical care here at VCU. Her professional interests include antithrombotic therapy, mechanical circulatory support, and cardiopulmonary resuscitation. We also have Dr. Casey Cable. She received her medical degree from Florida State University, completed internal medicine residency at Mayo Clinic in Florida, and pulmonary critical care fellowship at Emory in Atlanta. She's been here at VCU for 4 years and is the current director of resource intensivists for the health system. We have Dr. Jason Jennings. Dr. Jennings received his medical degree from the University of Virginia and completed his emergency medicine residency at EVMS in Norfolk, followed by a fellowship in clinical ultrasound and resuscitation here at VCU. He's been here for about 5-6 years and is the current clinical resuscitation fellowship director. We also have Dr. David Jessee. Dr. Jessee received his medical degree from VCU, completed internal medicine residency here, and joined the Division of Hospital Medicine in 2016. Since 2018, he's joined the Emergency Response Committee as a hospital medicine representative, and code team leader, has been involved in multiple initiatives to enhance team member response to emergency events, patient safety, and interprofessional collaboration. He's also the Internal Medicine M4 Acting Internship Director. Lastly, we have Dr. Brian Strife. Dr. Strife received his medical degree in 2007 from VCU, completed radiology residency and interventional radiology fellowship here at VCU, has been a faculty attending at VCU for more than 10 years. His clinical interests include venous thrombosis, pulmonary embolism, vascular anomalies, cirrhosis, and portal hypertension. He's been serving on the PERT working group since its inception. Let me turn it over to Dr. Marcelo to get us started, and a warm welcome for our speakers.
Sorry, I'm recovering from a cold, so I might sound a little weird. But thank you all for being here in person and also virtually. And thank you for that introduction, Dr. Bergman. I especially want to thank our panelists who are taking time out of their busy schedule to be here in person. So warm welcome to them. Before we get started on the case, I do briefly want to go over the general goals of MMI conference, which are to learn from and to engage in rational discourse surrounding medical errors and adverse events, to identify systemic errors, and to increase transparency regarding organizational improvement efforts. I'd also like to review the general ground rules for MMI, which are to avoid finger pointing and to maintain confidentiality and practicality in our discussion. The specific objectives for this MMI session on acute pulmonary embolism are the following. We're going to review the initial evaluation and risk stratification of acute PE, review anticoagulation and thrombolytics options and the subsequent management of acute PE. We're going to discuss interventional radiology approaches and discuss escalation strategies for patients who become hemodynamically unstable due to acute pulmonary embolism. The panelists and I have no conflicts of interest to disclose. So without further ado, let's dive into this very complex case. I'm going to try to go through it fairly quickly so that we can get to our panelists. So this is the case of Miss A.H. She was a 31-year-old woman with severe obesity and asthma. She was also on hormonal birth control for menorrhagia. She presented to the first outside hospital with acute hypoxia and was subsequently intubated, but she was still very hypoxic on the ventilator. So she went to the second outside hospital for ECMO. Upon arrival to the second outside hospital, she was started on VV ECMO. She had a transesophageal echocardiogram that showed an elevated right ventricular systolic pressure. And so she was started on inhaled nitric oxide and sildenafil for pulmonary hypertension. Additional studies include a lower extremity venous duplex and a pulmonary angiogram that were grossly negative. Notably, the duplex was suboptimal and technically difficult, and she was unable to get a CTA due to her body habitus. She eventually was extubated and the ECMO was discontinued, but there was difficulty weaning off the inhaled nitric oxide. So she was transferred to our institution for evaluation and management of pulmonary hypertension. Upon arrival to VCU, she underwent a right heart catheterization, which showed mixed pre- and post-capillary pulmonary hypertension, as well as no significant change in hemodynamics on or off inhaled nitric oxide. So the inhaled nitric oxide was discontinued after the right heart cath. She was subsequently transferred out of the ICU, but notably before transfer, she reported some left-sided weakness, which had started at the outside hospital. A CT head was negative for abnormalities. Upon arrival to the floor, her oxygenation was actually better previous. The team consulted neurology for the left-sided weakness. They recommended an MRI, but unfortunately she was unable to get this due to her body habitus. The team continued to work up her pulmonary hypertension and got a VQ scan, which revealed intermediate to high probability of PE. Subsequent CTA chest showed multiple bilateral pulmonary emboli and evidence of right heart strain, as well as pulmonary infarcts, which I will demonstrate on the next slide with some images. So I'm not a radiologist, but I picked out 3 images that didn't show everything that the CTA reported, but did want to highlight a few of the findings. So we see thrombi in the right main pulmonary artery, as well as some in the left distal pulmonary artery, mild enlargement of the right ventricle, and subpleural nodular ground glass opacities in the right lung concerning for pulmonary infarct. The team was concerned about starting anticoagulation for acute PE in this patient with a suspected stroke. Although the a repeat CT head was obtained and was negative, neurology still had a strong suspicion for acute stroke and recommended starting a low-intensity heparin drip. Interventional radiology was consulted. They advised against any intervention given her overall improvement. And she had lower extremity venous duplexes that showed an acute left lower extremity DVT. 24 hours later, after starting the heparin drip or thereabouts, her heparin drip was increased to the DVT PE nomogram. And after about 48 hours of being on heparin drip, her PTTs were finally therapeutic. Notably, neurology did feel that strongly that the etiology of the stroke was cardioembolic in etiology. So they ultimately agreed with full anticoagulation. Patients subsequently had an acute decompensation event after working with PT. An RRT was called due to acute hypoxia. And then the team subsequently called a PERT alert. She went for a level 1 CTA chest, which showed worsening PEs, worsening right heart strain, and worsening pulmonary infarcts. She was subsequently transferred to the ICU, where interventional radiology was consulted and planned for an aspiration thrombectomy. Again, highlighting a few of the findings on CTA chest, we see the worsening thrombi bilaterally, the worsening right ventricular enlargement, and the worsening pulmonary consolidations and ground glass opacities bilaterally. Upon arrival to the ICU, she was subsequently intubated, but she was still hypoxic on max ventilator support. ECMO was considered, but ultimately deferred, and the decision was made to take her to IR. Unfortunately, during the thrombectomy procedure, she suffered a PA arrest, and the anesthesia and ICU teams worked to resuscitate her and achieve ROSC a few times so that IR could attempt thrombectomy, but ultimately she was refractory to all resuscitative measures and passed away. So to assist in analyzing this case, I've developed this fishbone diagram of potentially contributing factors. I think that the most significant factors that contributed to this case was patient-related characteristics. She was severely ill and had a prolonged hospitalization at the outside hospital where she required ECMO, was intubated for a prolonged period of time, required inhaled nitric oxide, and may have suffered an acute stroke. Additionally, she had severe obesity, which impacted her ability to get certain aspects of her care, such as certain images, some interventions, and it may have affected medication management. This brings us to another contributing factor, which could be management of the heparin drip. She was initially started on a low-intensity heparin drip, but this may be reasonable because there was some concern for a hemorrhagic conversion of a highly suspected stroke. I think a more crucial point here is that she had a delay in achieving a therapeutic PTT for about 48 hours. And this could be in the setting of underdosing due to her obesity. But we can get into more details about that in our panel discussion. Other factors I had considered was the possibility of a diagnostic delay or error here. The CTA chest was not done immediately upon transfer to our facility. There may have been an anchoring bias at play here, with the patient being transferred for management and evaluation of pulmonary hypertension. There may have been a focus on that diagnosis. However, she did have a negative pulmonary angiogram at the outside hospital, so it's reasonable to think that it's not necessary to pursue a PE evaluation right away. Finally, a contributing factor that I wanted to consider was possibly suboptimal response in the PERT alert. A PERT alert requires multiple different teams to respond and requires a lot of communication and coordination between these teams, making it susceptible to error. Additionally, PERT alerts tend to happen in the ER, and this PERT alert happened on the floor where the staff may not be as familiar with the process. Ultimately, though, in this case, there was no overt deviation of care identified. I think this analysis demonstrates that there were some suboptimal conditions and a need for education and to re-examine our current processes. which takes me to our panel discussion. Want to welcome our panelists and to provide the education and transparency about what's in store for PERT alerts in management of acute PE. So the first panelist we want to invite to talk is Dr. Jennings from our emergency department to talk about initial evaluation and risk stratification.
All right, so I'm going to take kind of a little bit of a step back here in terms of this specific case and just talk about how we evaluate and kind of risk stratify patients who present to the ED with concern for pulmonary embolism. So this is a guideline that we recently revised in the ED that kind of describes how we approach these patients. So imagine every day we probably get about 40 or 50 patients who present with chest pain or shortness of breath or some combination thereof. So you imagine if we just decided we were going to CTA all those folks, that A, that would be a ton of unnecessary CTAs, and B, we'd find things we don't want to find, and we would completely eat up our radiology department with probably unnecessary testing. So this is a very well-studied well-described group of patients that gives us some objective criteria for how we assess these patients. So the first step is just indicating what their general pretest probability of PE or your pretest probability is. And there's a whole lot of different ways to do that. We typically prefer to do Wells criteria in the ED, but there are a lot of others that that folks use. So you're going to go, you can pull up the Wells criteria on MD Calc or actually in Epic. There's a scoring tool for it. And that will give you whether the patient's low risk, moderate risk, or high risk. And if they're low risk and they're PERT negative, we can actually just stop there because their pretest probability of PE, with all that being said, is essentially less than 2%, which we think is sufficient to rule out the diagnosis. The most common things for PERT that cause patients to fall out are going to be age. So you have to be less than 50 to use PERT. It's going to be heart rate. So any heart rate greater than 100 at any time during their presentation. And then for a female population, oral estrogen-containing contraceptive usage as well. There's some other criteria on there I'll let you guys look up if you're interested. But those are kind of the most common things we see as reasons that people don't meet PERT criteria here. So then once you've decided whether they're low risk or moderate or high risk, if they're low risk, you can pursue a D-dimer. And if it's less than 0.5 milligrams per liter, or if they're greater than 50 years old, we can age adjust that for 0.1 for every additional decade of life. So a 70-year-old, their cutoff would be 0.7. So if that comes back negative, then we're kind of done. And we obviously want to think about alternative diagnoses, but we're kind of stopping our evaluation for PE there. Now, if they're moderate or high risk, their pretest probability is high enough that your Bayesian shift with a negative D-dimer is not going to be enough to rule out the diagnosis. So we're going to go right to CTA in those patients. And if the CTA is positive, then we want to see if this is a submassive or a massive PE. And by that, we mean, is there RV strain or positive biomarker? So troponin, BNP. If you do and we typically will do a bedside echo in the ED. Also, you can ask for cardiology's assistance in performing that echo, but most of us, at least in the ED, and I think within your department, have become pretty comfortable with bedside point of care ultrasound to assess cardiac function. So looking for RV dilatation or things like McConnell's sign. So once you've made that diagnosis, obviously we want to start anticoagulation, and that's a much more complicated discussion I think Cassandra is going to touch on here. But if you do find that there is a PE, so you've actually diagnosed the PE and they have RV strain, that's when we're going to get into a PERT alert, and we'll talk about what that means in terms of what teams respond to that. We did additionally create this massive PE management algorithm in light of a few cases we've had in the ED. And I really just want to focus mostly on definitions. So what is a massive PE? Well, this is a confirmed PE, so radiographic evidence of an actual PE with hemodynamic instability and or shock. And we define that as a systolic blood pressure of less than 90, a MAP of 65, or a drop of greater than 40 points from their baseline for 15 minutes. Or vasopressor requirement, persistent bradycardia, or in a post-arrest patient. The second category of this massive PE is that cardiac arrest or peri-arrest patient that you have a high suspicion for PE, but you cannot get definitive imaging. So in those patients, we're okay with calling this a massive PE just because you can't actually get them to the scanner. That doesn't qualify for kind of the stable patients. you just suspect, we really don't want to activate a PERT alert in those patients when you're able to get diagnostic imaging. We kind of refer to that as a SPERT alert, the suspected PE response team alert, which really no one likes. So this is, again, for those sick, very unstable patients that you can't get to the scanner. These steps of 1, 2, and 3 are not necessarily in order, but something that the PERT alert does not include is the CT surgeons. So if they're sick enough to have arrested or be peri-arrest, we want to talk with those ECMO attendings directly to consider placing them on VA ECMO. We want to activate the PERT alert concurrently, and then we want to talk about thrombolytics and or catheter-directed therapy with our colleagues from the ICU as well as from interventional radiology. All right, so with that, I will turn it over.
And we'll have time for questions after everybody goes through their sections. So if you have any questions, please, I think, Dr. Berman, you were gonna keep an eye on the chat later on. All right, so moving on to subsequent management with anticoagulation and thrombolytics. We have Cassandra Baker here to talk about some of our strategies for anticoagulation, thrombolytics, and I will be over here in case we need questions. So.
Thank you all for having me. Of course, as a pharmacist, I want to focus in on our medical management of PEs. In doing so, I want to take a look at our available heparin nomograms that we have at VCU. So I'm sure you're all familiar with the 3 different nomograms with 3 different target APTT goals based on the indication and your patient's risks. There's a few other differences besides just our goal PTT. As you can see with the low intensity, this nomogram is really meant for patients who may have an indication for anticoagulation, however, have a considerable bleed risk as well. So in this nomogram, we're going to start at lower doses. We're going to omit any bolus doses just to try and more conservatively increase their PTTs without causing overt bleeding. Comparatively to our DVT-PE nomogram, you see we have a very high initial bolus dose. We start at a higher initial infusion dose and have very aggressive bolusing in these patients. And then our cardiovascular nomogram is sort of in the middle of all of those for our AFib patients. Importantly to note, and I think something that was really important in this case was the measure of obesity. So in our patient who was about 190 kilos, you can see that the initial dose per these nomograms is actually much lower than what the nomogram would generally recommend. And this is because we have a max initial amount of heparin to give per hour. So instead of starting between 10 and 18 units per kilo per hour, we're going to be starting the patient at 5.2 to 8.4 units per kilo per hour. And this is because we know that the general weight-based dosing in patients that are obese is likely to over-anticoagulate the patient and cause adverse events. So I have those listed here, but it's just an important consideration when you are dosing someone on obesity that is obese. They may not start at the usual dosage ranges. Importantly, though, our adjustments for our subtherapeutic PTTs are also weight-based. So even though we're starting at a lower initial dose, we're making larger adjustments for that patient to try and get them to goal. Now, as we mentioned in this patient, they were started on low intensity due to their risk of potential catastrophic bleeding. And as you can see, the heparin was started at 5.2 units per kilo per hour, which is consistent with what is recommended in the low intensity guidelines. And it was titrated correctly over the next 24 hours. However, the PTT remained subtherapeutic below 50. In about 24 hours, the heparin rate was 11.2 units. And at this point, there was a stronger concern for the PE, and that became more of our priority. So as Dr. Marcelo mentioned, the nomogram was switched to the DVT-PE nomogram. Now, as you can see, when that switch occurred, the rate of heparin was actually dropped from 11.2 to 8.4. So just looking at the DVT-PE nomogram by itself, that would be the correct initial dose as ordered. However, there has to take a little bit more thought into transitioning between these nomograms, because obviously if 11.2 isn't enough to get us to our PTT of 50 to 70, then dropping the rate is not what we want to do in order to be more aggressive. So it took about 26 hours for the patient, once the DVT-PE nomogram was started, to get to a therapeutic PTT, which sounds like a long time, but it's actually much improved from our prior Cerner days and the nomograms we had there. And, you know, in this case, it took about 7 hours to get from 8.4 to 11.4, which was the dose that the patient was on before. So potentially we could have recognized that we didn't want to drop the dose and really increase at that point, and that could have saved us anywhere from 7 to 14 hours of titrating heparin. But overall, the nomograms were followed. They were ordered correctly. They were followed and titrated correctly. So I think that's just a really important consideration, that even though if we're trying to do everything right, there are still some pitfalls and nuances of these nomograms, especially when switching between them. Looking at how we order the nomograms, you can see when you pull up heparin in Epic, the top 3 there are the main nomograms. At the bottom, you'll see we have options for the DVT, PE, and general cardiovascular nomograms without the initial bolus. These become really important when you are switching in between nomograms that they're already on heparin. You're not going to want to re-bolus them with that large bolus. And once you make your selection, there's really not much else for a provider to do. So the Epic heparin orders are very easy to order. There's nothing that you can edit on that order. It's all pre-built and set, which is nice that you don't have to think about it, but also it's a high alert medication. So we should be thinking about it a little bit more than just clicking a button. So especially in those situations where you are transitioning, taking a minute to sort of think about what the nomograms are doing, communicating with the pharmacist, the bedside nurse, just to make sure everyone's on the same page and we're actually moving in the right direction towards our goals. There is this note to pharmacy down here at the bottom of the order that can sort of communicate, hey, the patient's already on this much heparin. But that note is even hard to see for pharmacists when we're verifying. So I strongly recommend, especially in cases like this, having good, clear verbal communication with all members of the team. And then secondly, another aspect that wasn't necessarily taken in this patient, but thrombolytic therapy. So just briefly, our thrombolytics are breaking down plasminogen to plasmin to then dissolve fibrin clots. The two thrombolytics we have at VCU are alteplase and tenecteplase. Now, I will say alteplase has been our main workhorse in this patient population. Prior to this year, tenecteplase was restricted to the ED only for acute STEMI patients who couldn't go to the cath lab. And it also doesn't have the FDA-approved indication for treating PE. But looking at kind of the differences between these two, they actually both look exactly like this molecule that you see here. The only differences is tenecteplase is has a 3-point mutation at the starred locations. And that 3-point mutation allows it to have higher fibrin specificity, and it's also more resistant to the plasminogen activator inhibitor, which breaks down sort of circulating thrombolytics in the blood system. So because of that, it has a longer half-life and it's quite a bit more potent than alteplase as well. The dosing, Dr. Jennings already mentioned, but just thinking about how these products come, alteplase is 2 50 to 100 ml vials where you have to reconstitute with a spike. This process usually takes about 5 minutes if you have the drug in hand. We don't bring it to codes. So if it is needed in a code situation, we're going to have to, locate the nearest pharmacy to obtain the medication. So it is a little bit more of a timely process. Tenecteplase is an easy 10 ml reconstitution. The dosing is actually listed on the box, so you can get an idea how much the patient weighs and see exactly how many mLs to give. It's much easier, however, it's not quite yet readily available in the hospital, so your ability to get this as quickly may be more challenging. Thank you.
All right, so no discussion of acute PE is complete without a discussion on interventional radiology, and I'd like to invite Dr. Strife and so we can hear from his invaluable expertise.
Thank you. I have a few slides just to kind of review what we've been doing in IR. I've been here for 21 years at VCU, and that's really when PE work in interventional radiology started to become more popular. And then in the last 5 years, it's really become a huge part of what we do. So just kind of the schematic for looking at acute PE, how do we talk about PE? And there's the kind of the American way, and then there's the European way, and this kind of brings the two together. So there's really three main flavors of PE, right? There's low risk PE, there's what we call intermediate risk, AKA submassive PE, and then there's high risk, AKA massive PE. So the AHA stratification is 3 categories, which we use the language commonly submassive and massive for what we're talking about today. On the European side, and even in the American literature, we're trying to do is substratify to a 4th group, and that's the middle column there. In the intermediate risk submassive group, we're looking for patients who we call a lower risk, and then we're looking for patients who are higher risk within that submassive category, because those are the folks that we think are going to benefit mostly from a strategy that includes anticoagulation plus something more. And that plus something more is your 4th column there, which is lytics, catheter-directed therapy, or surgery. So just quick summary, the people who are going to get more than anticoagulation are going to be patients who are intermediate risk submassive, but have those higher risk features. And then, of course, patients who have high risk or massive PE, unstable PE, are always going to get anticoagulation and hopefully something more than that. So endovascular therapy or catheter-directed therapy, it really was just like use what you got for other stuff 20 years ago. And now we have companies that are specifically designing PE-specific tools. Mortality has come down really significantly from around 15% for our highest risk population, 20%, to now studies showing, and I'll bring this up later, mortality on the range of 1 to 3%, even in some of the highest risk patients. Morbidity is extremely minimal, despite the size of the devices going up dramatically. Our current system that we use every week in IR is 24 French. So it's a huge venous device. We started with devices that were 6, 7 French, and now we've only gone bigger, and bigger is definitely better when it comes to PE. The cool thing about catheter-directed therapy is we have the ability to attack clot on 3 levels. I call it melt, aspirate, and fragment. So melt is giving lytics. We can give lytics via catheters. Aspirate, meaning we can suck out the clot. And fragment, meaning we can actually break the clot up into smaller pieces, reducing the obstructive kind of surface area of the clot. It's not available to all centers, of course, and there's a high cost up front. But what I think the evidence is showing is if you really spend a lot of money on that first intervention and do an awesome suction thrombectomy, the patient no longer has to go to the ICU for 3 or 4 days. They're getting out of the hospital quicker. So you're spending more money on the device up front, but you're gaining a lot on the back end with the patient not staying in the hospital as long. So just a couple cases to illustrate kind of what we do in IR. I'll breeze through these quickly to really get to the system we're using now, which is the Inari FlowTriever device. So first patient just has an acute PE. We stratify it. This is what we do on PERT. We show up, we make the diagnosis. There's an acute PE. We risk stratify the patient, and then we come up with a therapy. In this case, it was a patient with a large occlusive right pulmonary artery embolus and right heart strain, hemodynamically stable. We risk stratify the patient. Here's the CT. You can see on the image there on the left, there's a huge embolus on the right. We see the heart doesn't look too bad, but we've got a massive clot there in the RPA on the axial and coronal images there. This is the angiogram. A right pulmonary angiogram basically shows a huge filling defect on the right with almost no flow to the right lung. This is not a good situation, and quite frankly, this is often not well addressed by us. This is often a case that surgical embolectomy works really well for because the clot is so dang big. But in this case, we ended up doing lytics. You can see on the left image, there's a lysis catheter in place, which is basically a sprinkler system for TPA. And there's the pulmonary angiogram 24 hours later, showing a dramatically different result with some residual eccentric wall adherent clot there, but pretty good perfusion to the right upper and right lower lobe. And the patient did well. So that was a 24-hour stay in the ICU, monitoring risk of intracranial and other hemorrhage from exposing the patient to TPA, and discharge on hospital day 4. This is the rationale behind catheter-directed fibrinolysis, is that if you have an obstructive clot in the right pulmonary artery, as we did in this case, if you give systemic lytics, you're basically washing TPA onto the wall of the clot, and you get these eddies. When you use a catheter that's actually bridging the clot, you're getting TPA in front, into, and beyond the clot. And so the theory is that you get a better penetration of the lytic into the pulmonary circulation. Now, of course, this only works in very simple scenarios, right? I don't have an octopus catheter that's going out into every pulmonary artery branch. So it's a little bit silly to suggest that this is somehow the magic bullet. But companies have thought about developing catheters that do have kind of this multi-catheter strategy. But at the end of the day, I think you're exposing patient to lytics, you're looking at a prolonged intervention, and you're not dealing with it right away. So we've really moved away from this. And I spent the beginning of my career doing lysis all the time for arteries, veins, and PEs. And now we've really moved away from that. Another classic case, we got a big saddle embolus in this patient. You can see the significant RV dilatation. For the RV to LV ratio, there is at least 1.5 to 1, so pretty significant dilation. Big pulmonary artery. Patient passed out suddenly. CT showed the saddle PE. He had recent major surgery, so he was deemed high risk or massive PE, getting anticoagulation, and then we considered additional interventions. In this case, we thought he had a contraindication to TPA because he was POD9 from recent esophagectomy. He did not want further surgery, so it kind of fell in our hands to work on him. And we did a very simple intervention. This is one of the first PE interventions that was undertaken decades ago, and that's just fragmentation. And the diagram on the left really shows why fragmentation works. If you have a single obstructive clot in the left main pulmonary artery, that bed is 100% occluded. If I break that same clot down into 20 small pieces, but it's only obstructing 50% of the peripheral branches, I've now opened up 50% of that lung. And this takes mere seconds to do with a catheter. And we have a couple different, catheters we can use to do that. The thing we don't like about it, though, is if you don't have this perfect setup and it's a semi-occlusive clot, and then I bust it up and then it becomes occlusive distally, you can actually worsen the patient. So again, it's not like a perfect strategy. It's really lacking what we want to do, which is just get rid of the dang clot, right? So he did great. You can see this is actually a 3-month CTA that basically shows clean pulmonary arteries. RV to LV ratio is normal. Not that we did anything, we just fragmented the clot. This is all endogenous fibrinolysis, right? This is the patient's body breaking down the clot, being on anticoagulation, which really cleans up a lot of these patients. You can look at CTAs on a ton of folks down the road who had massive PEs, meaning massive PE burden, and you can see that their pulmonary arteries are quite clean. The incidence of kind of chronic thromboembolic disease is pretty low, as long as they get on anticoagulation. And finally, where are we at now? Suction thrombectomy. So this is a 4-year-old female with a pretty significant vascular malformation in their chest. They developed an acute PE. You can see in this patient, we have a saddle and probably the most ridiculous heart strain anybody has ever seen on CT. So this is the reformatted image. You can see the RV to LV ratio is, 4 to 1. There's a huge saddle with an obstructive right clot. We did suction thrombectomy. The patient also was put on ECMO. And this is what the suction thrombectomy system looks like for pediatrics. It's just a bit smaller than we do in adults. And you can see all the clot that we sucked out there on the right with a size representation there. So in a 4-year-old, this was a tremendous burden of clot that we removed. Patient did great. Here's the pulmonary angiogram. A little bit of residual clot in that right upper lobe. You can kind of see the filling defect there. But overall, really nice looking pulmonary circulation. And interestingly, TTE showed normal RV function within 24 hours, which is the magic of being young. But she did great on anticoagulation. I still see her to this day, years later. So the coup de grace, or coup de grace, as we say in interventional radiology, is the Inari FlowTriever system. And this is really the pathway that we're at now. And to give you an idea of how many times we're doing this, so in the last 3 years, I haven't lysed a single patient for PE, and we've done about 120 cases. So we're averaging about 40 to 50 Inari FlowTriever suction thrombectomy cases a year. It's up to 24 French system. It has a really cool device that comes with it called Flow Saver, because every time we do a suction pass, we get 60 cc's of blood out of the patient. So the patient needs to be thoroughly anticoagulated to use the complete system, which includes this blood returning device. You can't use that if they're not anticoagulated. It's a high cost up front. It's about 12 grand. It requires a skilled operator, and the data is very promising. And really, in the interventional radiology world, there's a paucity of good data. And so it's really nice to see folks finally committed to producing randomized studies, massive registries, and this is really going to help, I think, shape the PE landscape going forward. Here's what it looks like. Here's a recent case that I did. Huge clot burden PE, severe strain on imaging, positive troponin, soft pressures. You can see the size of the device here. It's quite scary at first, but once you do it a few times, it feels like old hat. But we typically just go right to the side that the device goes to, do several passes. It usually works like magic. I'd say probably about 90 to 95% of cases are very, very quick. This one in particular took me about 45 minutes skin to skin. So it's a very fast intervention. We always do them with anesthesia support. We do them with actually very light sedation. We almost never intubate the patients for these procedures. And we keep them as awake as possible. We have the anesthesiologist team there, though, in case we do get into a critical situation and use their expertise. So you can see on the left picture there, very diminished flow. The left lower lobe basically has no flow. Huge clot complex kind of in the distal right main pulmonary artery. And then the completion pulmonary angiogram 45 minutes later just looks fantastic with just minimal residual clot. These are giant clot pictures. Hilariously, the one on the upper right is actually inches, not centimeters, so it's a little bit funny. But the one on the bottom is actually a 36 centimeter single saddle embolus that was removed en bloc from a patient. So literally the entire clot, 36 centimeters long, came out on a single pass. So that was a very rapid intervention. But most of the pictures look like this, predominantly a mix of purple, soft, spongy clot, acute clot, often mixed in with a little bit of whiter clot, which is typically subacute. The cool thing about the Inari system is the FlowTriever data that's coming out. So they have the FLASH registry, a large prospective multi-center registry, looking at these high-risk massive patients, as well as that kind of intermediate risk submassive patient. They've got 800 patients they've already looked at, all-cause mortality less than 1% at 30 days, none related to PE. That's pretty promising data. No device-related deaths, average post-procedure hospital length stay of 3 days. And almost 2/3 of patients never went to the ICU for the night. They've got the FLASH registry. They're doing this peerless study. They're going to do a prospective randomized study looking at FlowTriever to catheter-directed lysis. So that's an important study because a lot of people are still doing catheter-directed lysis that haven't hopped on to the 24 French suction thrombectomy system. And then peerless 2 is going to be super important. Also, large prospective randomized study looking at FlowTriever to just garden variety anticoagulation in those intermediate risk patients. And that's been a super important question because the overwhelming majority of PERT alerts are submassive or intermediate risk patients. And that's a gray area. How do we select those patients for advanced intervention versus just anticoagulation alone? And does it matter? Does it matter at 6 months or not? And then finally, FLAME was an important study which just came out recently, which was a prospective observational study looking at the system versus traditional therapies for patients with massive PE. And this is the drama point. 53 patients treated for unstable PE, massive PE, 1.9% in-hospital mortality. I think people were shocked about that because we were really looking at anywhere between 10 to 30% in-hospital mortality for patients with massive PE in a lot of studies using other therapies we've used in the past, including other catheter-directed therapies. A large registry had about a 15% mortality for catheter-directed therapy in massive PE. So now they're like, wow, this is really important. Where do we go from here? So that's where we are now. We use the Inari FlowTriever system, I would say 99% of the time, large bore suction thrombectomy. Thank you.
All right, so we've alluded a lot to PERT alerts and communication and escalation. So I invite Dr. Jessee and Dr. Cable to kind of talk about communication escalation. I have a few questions, so. If you want to see here.
Where's the camera?
I think right there.
I don't even know if they can see us.
Okay.
Yeah, so as of right now, there's the PERT alert that can be called. Typically, it is called more so in the emergency department. But every once in a while, we do get PERT alerts on the floor as well. But I think leading up to that, as you alluded to, is it's important to understand when it's important to call a PERT alert. So it's going to be those intermediate or submassive PEs. And it really, at that point, is really important for risk stratification. So we really come and need to evaluate to see if there's what prognostic indicators do we have, either being the blood work, right heart strain. Right heart strain is actually coming out more and more to be, poor prognosis. And so that would put you in that submassive intermediate category, would prompt you to probably get anticoagulation plus consideration of another therapy. PERT alert has existed, but it hasn't been here at VCU. It hasn't been as standardized as other places have. And so I think that's what we are currently working on. There's a really good algorithm working up to how, as in the ED, to really look at who falls into an intermediate or a submassive. But then after that, it was like, okay, call the PERT alert. And then it was just kind of off in no man's land on a variety of physicians would be involved and paged. And then how did that look? So I think that's what we're kind of nailing down a little more of a protocol procedure, kind of based off what some other very well-known institutions do as well. So kind of a tried and true proven system.
Yeah, and you have a question for me, Carol? Do you?
Yeah, so,
Okay.
If you have a patient where you, like on the floor, and you're diagnosing it, I think they are having progression of the disease, even to hemodynamic changes, how do you escalate that?
Well, I would say if you get to hemodynamic changes, you're borderlining from submassive to massive. So I think you'd want to involve us earlier. If you have a diagnosed PE on the floor, if you have any questions, you can, I would say, and that's where it gets into the algorithm of, do you have evidence of right heart strain? Do you have evidence of elevated BMP or troponin? That is going to escalate you into a larger category. That's when you would escalate. That's when you would get the PE team involved, because that is then where it comes into discussion with interventional pulmonary and then the MRCU and the pulmonary team to say, okay, are they going to be okay just on anticoagulation alone, or do we maybe need to consider doing a further intervention? Does that answer the question? I hope. Sorry, I was looking off to the side.
And who do you expect to hear from? Who do you expect to hear from when you call for it?
Can you repeat the question?
Yeah.
We're having problem.
Oh, absolutely. So who do you expect to hear from when a PERT alert is called? And as we're kind of working through that algorithm, the key players, the initial key players are going to be interventional radiology, pulmonary critical care in terms of the MRCU, and the KICU, because we need to get an urgent echo, because that is the evidence of visual right heart strain is so important and for risk stratification. Those are going to, in my head, those are going to be the three primary players that are going to be notified. Pharmacy as well is now, it's also on the pager just in case, so that they're not surprised if we start asking for things. They can, they're not necessarily come to bedside, but they can at least chart review and be aware if we do go down a path. But those are the key players. Now, if things start to become unstable, or if the decision by our interventional radiology experts are, you know what, this might be, given how the scan looks, given what's going on, this might be a discussion that we might to include CT surgery, or if the patient does decompensate, think about ECMO. Then those key players can then be paged to be involved.
And then what?
Yeah, you have to repeat it. They'll hear
You can repeat. I can repeat.
What work are you guys doing on ERC to enhance that real-time dynamic collaboration and communication?
Yep, great question. So as of right now, that's why we're not sharing it, because it's still a process. We want to make sure all the stakeholders have vetted it, are comfortable with it, all the details on how that communication is worked out, and that's some of the details we're vetting right now. On exactly how we're going to work on that communication between all the different groups. Epic's changed things because there's different ways you can communicate via Epic. We have chats, we have other pages. So I think really narrowing down to make sure that that there aren't going to be lapses in communication is going to be key for making this sustainable.
That's all the questions open up to other questions.
Yeah,
Anybody have
we
any?
can open up here for any
Yeah.
questions in the audience?
You guys have any questions for interventional radiology, pharmacy, ED, hospital medicine? The amazing palm crit.
Sure, I'll ask one. Thank you, everyone. One question for you all. You've mentioned,
Can we give you the microphone real fast?
I can just speak louder.
Yeah, it won't work on the.
You mentioned VA ECMO a couple of times, and it's not part of, I think, our usual thought process in the cardiac arrest.
Mhm.
A, who should we be thinking about for VA ECMO? And then B, what does the process look like when we want to call for that?
Okay, so the question revolves around VA ECMO. That's not classically for these is more VV, but if there's a decompensated patient, who do you call? Who do you escalate that to? In my understanding, it's going to be more CT surgery is my understanding, is that's exactly who you call for evaluation of what you might need. I may have because you guys do more ECMO than we do in terms of PEs. I mean, I've only rarely had to push TPA during a code situation, but so that's up to my experience.
Yeah, so great question, because logistically it can be challenging, right? In the moment on telepage, there's an ECMO attending listed, which is one of the CT surgeons. Is not always going to be the same as the CT surgeon attending. So you just search for ECMO, they'll come up and they expect to get a direct page. We actually in the ED have a list of their cell phone numbers, so we can just call them because it's such a time sensitive intervention. Which are the right patients for that? That's also a very complicated question that could probably be an hour on its own. What I have found is that people will often look at the heart and see the RV is big intra-arrest and say, "Oh, it's definitely a PE," which there's pretty good evidence is not the case. Now, if you have somebody who just was a trauma patient, has a big cast on, and you see a big RV, you know, something by history, something else besides just the RV. But what we have found is that intra-arrest, every single RV will dilate to some degree. So just relying on that echo alone is not enough. But suspicion, you know, high suspicion before, and you see a big RV, we just call the ECMO attending and let them kind of make the decision, and they have some criteria they go by.
Any other questions here in person?
I guess going back to the case, and great cover everyone. Do you think initially the initial CTA was not timed appropriately, or was this a comment on maybe we could have done differently with the patient? And early intervention, maybe that would have more helped maybe earlier.
The first imaging study, I think, was a pulmonary angiogram at the outside hospital that was called negative. I think it's probably, I was involved in the case. I never saw the pulmonary angiogram. Pulmonary angiograms are not the gold standard test for diagnosing PE. They used to be, but CTA-PE protocol is, and there's very good reason for that. To not belabor the point, I've literally walked into a pulmonary angiogram where there's a saddle PE on the screen and nobody can see it. And that's the nature of a 2D planar image with contrast flowing around a log sitting in a pulmonary artery. So it's highly likely that that pulmonary angiogram was not negative, not even close, but the limits of pulmonary angiography, and in particular, somebody with a BMI of 69, was that that test was not very sensitive. And so I think it's highly likely that that pulmonary angiogram, to the best of their ability, yes, it was negative, but probably not actually negative. I think that's a really important point. We used to get asked to do a lot more diagnostic pulmonary angiography for PE, but I think, you know, there are some real significant pitfalls with interpreting them over a CTA-PE.
Yeah. And I think in this case, with this case is difficult because she was not transferred here for that. She was transferred for pulmonary hypertension. And in that workup, they did the VQ scan, which was high probability, and that then led to the CTA. So I think it wasn't, it's a tough case.
So you try to tell us what you know our criteria on the floor when people are deteriorating. How much deterioration do you want to see to follow the alert?
Go for it. I've got a thought, but yes, please.
Can you repeat that?
Yes.
So Dr. Syme asked the question, you know, can we quantify how much deterioration we would see before we're calling a PERT? And I think what we learned from this case, and what we're still learning from this case in particular was, as you guys have heard, was a very complex, challenging case, and not close to the typical patient that we manage day to day with pulmonary embolism. This was certainly one of the extreme cases, but I think what's good about this case is that it highlights the amount of expertise and knowledge that when a PERT is activated, you can get to the bedside and can get that additional help. And I think from a hospital medicine perspective, because this patient was on the floor when she had an acute decompensation, it can be very scary in that moment when a patient has already come out of the ICU and is deemed somewhat stable, is stable enough to be getting physical therapy, and then has a rapid decompensation. where we have a diagnosis of pulmonary embolism at that point. And so the team acted quickly. And I think that in this case, even a rapid intervention and rapid communication, when the patient, you're unable to oxygenate that patient and the blood pressure is dropping rapidly, a few minutes can feel like hours on the floor. And so I guess to answer your question, Dr. Syme, I would say that it does not require much decompensation at all. And in fact, one of the things we want to emphasize, I think, in the work that we're doing, we're all part of the team that's working on the PERT, kind of revamping the PERT algorithm, is if you have any suspicion, that's the time to call the PERT. And you get that expertise and knowledge at the bedside. And hopefully you're able to say, hey, you know what, things are stabilizing, things look okay, we can continue traditional anticoagulation. Or, oh, we have this amazing new therapy that Dr. Strife and his colleagues could do. And I think we've all been managing these intermediate risk patients like this for a long time, but to see in the literature that they're starting to be described as a low risk intermediate and a high risk intermediate, I think that is really those patients, those high risk intermediate patients where they're not hypotensive and they're not refractory hypoxia, but certainly could benefit from an advanced intervention. Those are the ones that I think we really need to be focusing on. And getting the PERT, calling the PERT and getting that knowledge, that expertise at the bedside, I think is one of the big things. Yeah. Mm-hmm. Mm-hmm.
Is there any consideration of it not, especially for the intermediate high risk of follow-up? So if sort of initial assessment is just anticoagulate, no additional interventions or therapy, is there thought that someone from the team might review that case in 12 to 24 hours to see if that's still appropriate or not? Or does that happen?
I can tell you from our team that we occasionally, depending on what we saw, will round on the patient again. So like if they had a significant residual DVT and we were considering a filter, maybe that would go onto our rounding list. It's often a one-stop shop though, because quite frankly, the vast majority of them kind of declare themselves. I think we've gotten very good with selecting who to take and who not to take. And because at least from the catheter-directed side, we like doing it. And so we're a little bit more aggressive, I think, with taking patients. Whereas, when you're doing lysis, you're always worrying about a bleed. And so like, we don't have to worry about these other technical problems that we had in the past. And so we're much more likely to take patients for this suction thrombectomy in the intermediate risk. So I think we're seeing a lot less patients that we passed on that then have a problem down the road. You can always reconsult us individually if there's a concern, and you can always call a PERT alert. Again, I've absolutely seen that before. But we don't have a built-in currently rounding mechanism. And just one more comment I would say to what was going on. All patients with intermediate risk PE, submassive PE, that's appropriate to PERT us. The thing I really don't like to hear is like, we just called y'all because the patient's doing fine, and we didn't call a PERT alert. Well, I want the whole team there because that's the whole point of it. It's a collaborative effort among all of us to, I'm not you personally, just in general, I hear that a lot when we get called individually, and it's like, if they have a submassive PE, intermediate risk, a massive PE, high risk, call a PERT. That's the whole point of the team, is to be there and help make decisions, help completely stage the clot, get things moving in the right direction. It's appropriate.
And I'll second that, because the definition of an intermediate, submassive PE is the patient's doing fine. They haven't crashed. That is now massive. And so I agree. And that us being, knowing the literature and suited more for, I suppose, experts, but yes, knowing the literature and knowing kind of what things are poor prognostic indicators can help us guide teams who not just, internal medicine, but also, some other services. We have so many services in the hospital who are excellent at what they do. And then us being able to be there, kind of help give guidance, I think is crucial. And we don't currently have follow-up, because with risk stratification now, I have not seen it as, I think I only saw one time that we had to recall another PERT, and they actually called a rapid first, which is also frequent. The nurse is usually calling the rapid first, and then we can show up, and then we can call our own PERT. When education on that, but usually patients either if they're that intermediate risk high in that zone, then usually they do go for some other therapy. But if they're in that low, typically after they're on anticoagulation, they usually don't decompensate further classically. But if they do, we can redo things.
All right, well, thank you, guys. Just want to thank our speakers. Thank you all for the staying around. If anybody has any other questions, please feel free to come down. We'll stick around for a couple minutes. Thank you all for joining us today. If you didn't get the CE credit, here it is. If you want to take a picture or chat it, we'll leave the screen up for a few minutes. Thanks for your time. Oops, sorry.